Thank you so much, and thank you for those who are decided to stay. I know it's a long day and it's been after lunch, and so I hope I can wake you up if indeed you're falling asleep. So this is an ongoing project at the Centre for Digital Transformation of Health. We're looking, what we've done so far is that we've co-designed a framework, a consumer engagement framework, but it is ongoing, and this piece is a self-reflexive piece, so it's almost like we are researching ourselves to make sure that we're doing this right, and we're using consumers and researchers together to do this. So I too would like to acknowledge the lands on which we meet today. We're Wurundjeri people of the Kulin Nation, and I also acknowledge that these lands were never ceded, and it's important to say that. So I'm actually a consumer activist, representative, advocate, whatever you want to call me. I'm one of those people who's agitated like a yappy little terrier around the ankles of government, bureaucracies, service providers, and policymakers to make sure that we can improve health outcomes for lots of people. I started off in maternity services for improving birthing outcomes for mothers, babies, and their families. And I branched out to women's health research. I'm now in general public health research, and with a specific focus on digital health solutions. Dr. Cara Burns is my manager, and she's the one who spearheaded this piece. She actually started the development of the framework, and I'll take you through that right now. So the vision at CDTH is, of course, a place where we want to see consumers have a say in the future of digital health, and our purpose is to actively involve consumers in all of our research activities. So we've mentioned the NHMRC earlier. The NHMRC, I look at this question, it's why partner with consumers? My question is why not partner with consumers, I have to say. So your NHMRCs and your MRFFs of the world are saying that they're this close to mandating that we actually need to have consumers involved in every single research piece. We've got the National Safety and Quality Health standards. Number 2 is partnering with consumers. We've got international support through guidelines through the National Institute of Health Research. They've developed, with extensive consultation, an amazing international set, an exemplar of principles, which we drew on. And I'll also just give you a case study here, which is Fostering African American Improvements in Total Health, which FAITH is the acronym. This was a case study which is a beautiful example about what we're talking about, where health outcomes can be improved with communities being involved. This is an African American community in Minnesota. They had a high level of cardiovascular disease, CVD. They were enormously concerned about it. They had a 4 to 6 times higher rate of it than non-African Americans. They were heavily connected to their local churches. They had outreach liaisons from the churches that were connected into community, and those liaisons were also connected to the university. So they were able to raise enough funds to create this beautiful research project to find out how they could improve health outcomes for those African American people in that community. So they went to the community first and they said, what do you want? So it was brilliant. The ideation started right from the community. They didn't say, this is what we'll do for you. They said, what do you want? What do you think you want? What do you need? And they all said they wanted an app, but they wanted an app that suited them. They wanted an app that motivated them. So they worked with the church liaisons, and those liaisons helped build trust, because there was a lot of racism in that community. And that helped build trust between the researchers and the community. And what they did was they came up with this app. This app got, check this out, 98% uptake. That's extraordinary for an uptake. Like you're even hoping for 60 to 70. That's kind of cool, isn't it? But 98%. This is the reason why. Every time there was a prompt from that app, it had a message from the scriptures, something that made them smile, something that made them feel good and happy that came from the Bible. And so they acted on the prompt. They went for a walk, they checked their blood pressure, they made their next appointment, whatever it was, and they did exactly what that prompt told them to do. And lo and behold, the health improved in that community. So I just think that's a really, really beautiful example of how community involvement, right from the very, very beginning, can actually improve health outcomes. So this is what we did with putting together our our framework. So this was the methodology. First of all, before my time at the center, they held focus groups with the staff members. We then, when I came on board and they showed me this framework so far, what it was contained. And I said, did you co-design that with consumers, if it's a consumer engagement framework? And I got crickets. And so I said, I think maybe we need to actually ask consumers about this framework. So we held a workshop, and then we conducted consumer-led staff interviews by moi. I'm the consumer. I'm your in-house consumer expert. I'm not a researcher. I come from the community. I bring that community voice in-house, and I stay in-house, and I'm connected to outer communities and networks, and I bring those voices to the table. So I interviewed staff to find out how the framework was indeed playing out in their work. So the focus groups began with the staff. This was before my time. And these were the aims of the focus group, was to recognize the benefits of indeed having CCI, consumer and community involvement, developing a set of principles that they'd like that would underpin the work, describe the roles and associated remuneration fees of consumers, because we know that there's like a sliding scale. There's people who sit on ministerial committees. There's people who are in focus groups. They're very, very different. You pay them differently. You engage them differently for different lengths of times and for different reasons. And also they explored the role of the consumer engagement manager. So they wanted a dedicated person. That's me. So they gave me a job. Okay, so these were the benefits that they recognized, that there was enhanced local knowledge, it supported industry transformation, great leadership in best practice of CCI for benefits of consumers, sharing a voice, learning new skills, capability building, contributing to digital health. I mean, what's not to like here? Working with people who respect equity, diversity, inclusion. CDTH is really, really big on that, inclusion and equity. We actually have an in-house equity researcher because of that, and growing improvement of the university's reputation, and we're helping to grow that as well. We now sit on the faculty for medical and dentistry health services, working up CCI and how it should look like right across the faculty. So this was what the framework like. This was the version 1. Okay, so there was your consumer engagement manager. I'm now known as the consumer engagement specialist. I'm a specialist now. We have a diverse consumer network, and I bring that to the table by building relationships with those external bodies so that we can get diversity whenever we actually have consumers involved in our projects. We looked at the roles from fast feedback right to being a research partner on research teams, so we have that vast array, and we also pay accordingly to that different tiered system. The benefits, as we've just gone through, which was the knowledge exchange, industry transformation, that type of thing, and the values. And this was really, really important to them. So I just want you to take note of these values for a second. Deliberate and purposeful, empowering and safe, tailored, reciprocal and responsible and responsive. So I just want you to kind of hold that in your one self for a second. So then we held the workshop with consumers, and the reason for that was so that we could look at the framework and go, are we on the right track? Did we do the right thing? We missed out on involving you. So this is the wonderful thing about CCI and co-design. If you don't start off with the ideation, it's okay. You can still turn it into co-design and get consumers involved, which we did. They reviewed the principles, so I want you to think about those 4 principles for a second, because what we did was we brought the NIHR set of principles in as well, the National Institute for Health Research, brought those principles in and said, do you like these instead of those? Do you like them both together? So we had a look at that. We actually confirmed the contribution, or the confirm and contribute to the consumer roles, as I've just talked about, and describe my duties of overseeing this entire program. So these were the questions that we asked. In the framework, what stands out to you? Which of the principles do you prefer and why? Anything else in the framework that we should actually have in there that we haven't put in there? And is there any barriers that would stop us from playing this out? And these 2 answers that you can see on the screen were the top 2 answers that we actually got when we surveyed our consumer group. Incidentally, our consumer group that we attracted for this had Indigenous, cold, LGBTQI, people from the disability sector, adults, older adults, men, women, gender fluid, rural, neurodiverse. That was my beautiful group of consumers who brought their thoughts and insights to the space. I'm very proud of them. So then we interviewed the researchers. I got to interview the researchers. It was actually quite a delight. These were the aims: explore their experiences with consumer involvement, review the principles, confirm the consumer roles, and just to explore to see if that consumer framework was actually playing out in their work. And you know, it was really interesting. Some of those researchers didn't even know that the framework existed. And all of these things, with some of them, were playing out. And it was organic. It was like it was just happening organically. These researchers were actually behaving or taking on this framework without even knowing that it existed. I thought that was absolutely gorgeous. So this is what came up. This was our different framework. Okay, and these are the changes that happened. So we had really good leadership from the these aren't published yet, so you can't use them. Sorry, but I'm just sharing them with you today. We have really good leadership support from our acting director, from my manager, and they've also given my role is now permanent to make sure that CCI is strong and it's meaningful within the centre. We have measurement and accountability in that space. We're checking ourselves all the time. We have a toolkit involved. We have a toolkit that has been developed so that it shows the researchers how to recruit meaningfully. So if I get hit by a bus, they're going to be able to do it all right. We have it in tiered. We have level 1, level 2, level 3. Level 1 is you can call me up for advice. Level 2, you can meet with me and have me talk to you a little bit more about it. Or number 3 is I can recruit for you and be involved in your activity. If you have a look there, it says independent. That was really, really important. We've got to be careful that when we bring consumers into any institution whatsoever, including the Department of Health, that you do not enculturate us. Okay? It's really, really important that that voice remains independent and, dare I say, provocative at times. These are the set of values which are now called our principles, and we're actually in that next session that Lucio mentioned. We're actually going to talk about those principles a little bit more. But this is what was added to. So it was originally deliberate and purposeful. They added maintaining relationships. That came from the NIHR. We kept reciprocal and responsive. Inclusive used to be empowering and safe. They changed it. They wanted it to inclusive and space. So that's what we did. Sharing of power, that came from the NIHR, but that has since changed again because my Indigenous colleagues have said to me, be careful about the usage of the word power. It is post-colonial. It is associated with the domestic violence against women. So I said, what else could you use in there that still means, what are we going to do when we have to share that leadership position? What does it mean? They said, use leadership instead of power. So it's been changed to share leadership. And tailored. We tailor our projects to match the population that we are researching and that we're working with as partners. Yeah. So that is it. I made it. 2 minutes to go, and I made it. I heard you, Lucia.
Thank you very much. Okay, we've got a couple of minutes on my watch for some questions or comments or clarifications, but thanks, Leslie. Anybody? Leslie, can I ask, discomfort and continuous learning.
Yes, I forgot to. I'm so sorry about that. That came out. I forgot all about that. I was looking that way. That was. I love that one. Actually, I do want to take it back. Yeah, because I did miss out on another thing too. Discomfort and continuous learning came out of the interviews with the researchers, that it's actually, you are going to feel uncomfortable at times working with people with varying different agendas, and consumers bring different perspectives to the space, and it's okay to feel uncomfortable, confused, not knowing what to do next. But your principles are really, really important to be in place, and everybody needs to sign up to them at the beginning of the project to make sure that discomfort is actually worked through respectfully. Okay, and it's okay to feel. And the other thing that I forgot to mention here, which is really, really important, is ways of working. I really love this wording, which is defending CCI to our external partners. We are uncompromising in these values, and we will call you out if we falter in not using those values at every step of the way, to the point whereby I've asked that our values, our principles, have been printed out. They're on a poster, and they're now up on our wall in our centre, so that we can say, even if when you get to a prickly moment when you're with consumers, or even indeed, dare I say it, senior clinicians and or researchers, you can actually say, hang on, can we stop for a minute? And you can point to the values and the principles and just say, are we going by these right now? It's okay, but it does require courage. It's a different way of working, but we defend it to the hilt.